Thank you, RJ. It's a great pleasure to be here. What a great conference. For cardiology community, we face this from time to time. It's a rare occasion. But I think that the time is ripe now for us to consider an international consortium to assess cardiac tumors, to understand the epidemiology, to understand ways that we treat it, the variations in practice. And I'm going to make a pitch for us coming together. I spent most of my career in New York City, the last 10 years in Toronto, but getting folks to work together, that's what I do, and I'm the Vice Chair of Medicine for research for the University of Toronto and 9 hospitals. And, getting people to work together has to be a win-win. And I think in this field, because of some of the statistics that I'll show, we really have to work together. And I would also venture to guess that there wouldn't be a competing international registry if we did one well and we included everyone and we're as inclusive as we could be. I think we will achieve this. I want to thank RJ for his leadership here at our institution and for this conference. And it's a pleasure to work with him, and it'll be a pleasure to work with everyone. And I don't think there's anybody more altruistic and more collaborative than RJ is. And so I think having him at the helm really makes me feel confident that we can work collaboratively. So we've talked about interact. We just came up with an acronym. I want to thank my fellow, Gil Marcus. Gil's in the back there. He's from Israel. He is a budding interventional cardiologist. He's a fantastic clinical cardiologist as well. And he and I we're the supporting cast. So we're going to lay in the background and provide some of the methodologic, statistical, and organizational structure to this as we get started. We're going to have a low budget, so we're going to all have to pitch in. But I think having fellows involved and trainees will also help us to be as inclusive as possible. So we know the state of the literature, and I'm going to present this as a cardiology perspective, but we do trials of 20,000 patients. I have a trial presenting at American College of 5,000 patients. So for us to do thousands of patients with PCI, bypass, is not that much of a stretch. So we can measure important outcomes like mortality, myocardial infarction, stroke, and so on. But in this field, there are challenges, and you know them. So the largest published cohort to date is 323 cases of myxoma. There's some clinical data in one study going back 28 years on 35 cases of primary cardiac tumors in a single center. And contemporary studies mainly focus on imaging of these tumors and on mechanistic and sub-study type of outcomes because we just don't have the clinical endpoints. The knowledge gap, I think, are multiple. One is, what is the best way to treat these tumors? What is the best surgical technique? What are the centers of excellence? Should we have 25 centers around the world that have expertise, or should we be able to operate in most large surgical centers? Are there different patterns of disease across the world based on genomics and based on other other factors? There's no single center or even a national consortium, this is Gil's words, and he's emphasized this to me, can answer these questions alone. And RJ has been the one to champion this, that we need to all work together if we're going to answer the questions that are needed. The primary cardiac tumors, as you know, they're rare. They're in about 0.02% of autopsies found, some of them incidentally, some of them not. A third are myxomas, a third are benign tumors, and about 25% are malignant. So there are some challenges here in characterization of the tumors, how we manage them, and the adjuvant therapies that we've talked about today. The secondary cardiac tumors also are more common. Obviously, we want to treat these comes from a disseminated primary disease and often are overlooked until we are far advanced in disease. I'm going to present a model, and we're going to have a lot of time for discussion. I'm not going to show that many more slides. But I want to use this as a model of how I think we can construct the registry. So this is IRAD, which is the International Registry of Acute Aortic Dissections. It was started a number of years back by my colleagues Kim Eagle and surgeons around the world. Kim was a cardiologist, and he was a clinical epidemiologist. And they recognized, again, they're dealing with an uncommon disease, not as rare as cardiac tumor, but it's 2 to 3.5 cases, 2 to 3.5 cases per 100,000 per year. And they created this registry to assess the etiologic factors, modes of presentation, clinical features, treatment, and hospital outcomes of patients with acute aortic dissection internationally. And you see here, these are the centers that have participated in 11 countries, 30 centers, which is impressive, but not staggering, and established in 1996. So we're coming up almost on 25 years of the IRAD. And it's been celebrated actually as a model of how to study uncommon disorders and how to pool our data and work collaboratively. You see the institutions here. Many of them may represent yours. Of course, Toronto General is in here, and the Toronto institutions across the United States and North America, and then, of course, in Europe. But you can see here that we have no representation from South America, Africa, and only a few centers in Australia. So, so there are challenges in getting centers up and running. There is an infrastructure required, but it's becoming easier to collect data over the last few years. The coordinating center here is in a single center, and I would advocate that we have a model that the NIH uses, National Institutes of Health, National Heart and Lung Blood Institute, where I work very closely. I've had a number of my own trials there that have been funded, and I work as an advisor to them. Informally, but I'm involved in a lot of the backroom discussions about how we move forward. So I think there would be a lot of appetite for this kind of registry. Having a coordinating center is important. I would advocate for multiple lead centers with PIs. I would advocate for a single clinical coordinating model, and then also a data coordinating model. The reason for that is when you apply for large grants, you have to apply for clinical coordination and data coordination separately. And if we're truly going to be collaborative and international, probably have at least two centers leading this. And I think that allows us to have checks and balances. It really works well. So in our trials, we've worked very closely with Mayo Clinic. We have a large bariatric surgical study with the Cleveland Clinic. We've worked with the University of Pittsburgh. At NIH, they require that at least 50.1% of the dollars are spent in the United States. So that means it's likely that we're going to have a major coordination effort in the U.S. in order to go for NIH funding. But we can go for other types of funding from other peer-reviewed agencies, the CIHR in Canada, the Australian MRC, and in Europe as well, different countries, and in the UK. So we have the opportunity here to really have an international footprint. IRAD publications since '96 is 151 publications. Again, a very robust publications committee, which has a democratic flavor to it. It's led, and they're rolling over members so that there's new blood coming in. It's not the same people publishing the same work, first and last author, the same people. We don't believe in that. I know RJ's the biggest believer in the collaborative approach, so we want to assure you that if we're successful, everyone in this room will be able to lead a major aspect of the registry. So Interact, for the reasons we talked about, is a multinational, multi-center registry, which we aspire to gather enough data to create a platform for investigators to interact and conduct future clinical trials, and I'll talk about that in a moment, in order to answer all the questions we need to answer. So the issue of there is the observational element of this, which I think is important, but ultimately if we're going to change practice, we have to design prospective studies to evaluate new therapies and approaches. And in order to do that, we would embed a clinical trial in the registry. So we'd if we're collecting all the data, so that's one aspect, collect all the data, and then within the registry, consider randomizing patients, which allows us to identify the patients up front. We don't have to hire people to do that, and we don't have to hire people to follow them. We've already been doing that in the registry. And this has reduced the cost of clinical trials to about 1/8. And that's the new approach. Actually, even with industry, we're pitching large, pragmatic, registry-embedded clinical trials. The other aspect here, which I want to throw out, and I'd love to have a discussion, RJ, about it, is the use of retrospective data. There's no reason that if it's collected properly that we cannot start off with some evaluation of retrospective data that's collected in all of the centers. We probably would start with vanguard centers, maybe 20 to 30 centers that are, if we're lucky to have that, vanguard centers that participate and each contributing their resources early on to get us started. I think that I'm going to leave that there. I think we have a very robust data collection system, which is web-based. It's called the eSocDat system, which we use in Toronto. It's used in Boston as well at Harvard. A lot of the Harvard clinical trialists use it. It's a very it's a wonderful system. It triggers you to fill out case report forms, triggers you to make payments to sites if you have to. It triggers you to have patient visits. It's probably the most complete system we have. It's all web-based, so data entry can be once into the system. And finally, I think each center should have access to their own data. So there's no reason for you to have your own registry. We talked about using REDCap and other systems, and we've done that, and that's important. But if we do this right, you'll be able to have access to your own data, and we will create regulations as to whether we would support single center reports versus multi-center reports. But there's no reason why you couldn't compare results from Adelaide, Australia to Calgary, Alberta, or whatever. We know we could compare outcomes in different healthcare systems. So it can be something that's that everyone has access to, but we really have to work on the governance so that we make it as robust as possible. I'll stop there, and hopefully we'll have a discussion, RJ. Thanks very much.